Pathogenesis and virulence. Enterococci is the part of our normal gut flora. The presence of other bacteria that carry pheromone plasmid, which forms bacteriocin molecules that is responsible for keeping a check on Enterococci colony and for cell survival. The overuse of antibiotics has led to an increased number of invasive infections by Enterococcus. Enterococci is a very resistant group. The use of antibiotics that kills other microflora of our gut, due to which there is absence of bacteriocin, and Enterococci now can grow freely, and it leads to an increase in colonization. When there is increased colonization of a single bacteria in our gut, it is a main factor for invasive infections. The Reg gamma 3 immune signal also keeps a check on Enterococci. The Ephasium is the most resistant species of Enterococci, and the use of antibiotics makes this bacteria isolated not only in our gut but also in the blood, which gives it a chance to grow. The virulence factors. It has two special virulence factors, two group of virulence factors that are Enterococci secreted factors and Enterococci surface factors. The Enterococci secreted factors are hemolysin, cytolysin. Cytolysin causes lysis of RBCs, WBCs, basically PMNLs. It produces proteases, gelatinases, serine proteases, which all together are responsible for modification of immune responses, antibiotic mechanism, and cytokine action, and also these all together neutralizes antibodies. Enterococci surface components. These includes adherins, which are responsible for attachment to gut cells. Aggregating substances. By using these, the bacteria are capable of aggregating and sharing the plasmid by process of conjugation. They have Sg, gamma A, FMS, MSC, RAMS molecules, which provide them capability for fiber and collagen attachment. They have SCM and also pili, which are important in forming biofilms, which is responsible for endocarditis and also pharyngitis. They have teichoic acid and which is immunogen, and I have already talked about teichoic acid in my previous videos. They have special gene, that is GLS24 gene, which provide then resistance against bile and salt. Because of this, they can grow in bile and salt medium. They have ASR gene, which provide them capability of resisting the oxidative stress. In less oxygen environment, they can easily grow because of this ASR gene. Clinical syndromes and diagnosis. It is associated with UTI, bacteremia, endocarditis, CA-associated endocarditis, meningitis, intra-abdominal soft tissue infections, and outbreak in neonatal departments. In UTI, generally it is associated due to catheterization and normally resides on removing the catheter, and also is associated with long hospital stay. It is the most common cause of UTI overall. It can be associated with prostatitis, which is less seen, but prostatitis can be a complication because there is a reduced penetration of antibiotics against Enterococci in the prostate gland. Clinical features such as fever, inflammation, and pyuria can be seen. For diagnosis, When there is more than 10 to the power 5 units of bacteria per ml, it is considered as a positive diagnosis. Bacteremia endocarditis and CA endocarditis. It is the second most common cause for bacteremia and endocarditis after Staph aureus. It is associated with cannula, catheter, GI injuries, pelvis injuries, and it can lead to bacteremia, bone infections, and seeding complications. And endocarditis. C. endocarditis. It is a special situation which can even be seen in a patient with no history of cardiac pathologies. Clinical features such as subacute fever, weight loss, malaise, valvular murmurs, petechiae, ossular node, Rath node, embolic complications of brain, arthralgia, hiccups, left flank pain, heart failure, and valvulopathy can be seen. Meningitis. It is very less seen due to enterococci, but can be associated with CNS injuries, shunting procedures, and it can be hematogenous in patient with HIV and immunocompromised ones. Clinical features and complications. Clinical features of normal meningitis will be seen, but complications like hydrocephalus, stroke, and brain abscess can be seen. It is majorly associated with strongyloid stercoralis as well. So these two bacteria together present in the blood increases the risk of meningitis. For its diagnosis, when there are more than 500 PMNLs per microliter of CSF, then it is considered positive. Increased serum protein, reduced glucose amount less than 28 mg per ml is seen. Abdominal and soft tissue infection. It is mainly associated with surgical procedures on abdomen, can be associated with peritonitis and peritoneal dialysis, hepatitis. So before surgical procedure, it is recommended, basically the surgical procedures on abdomen, it is recommended to give anti-enterococcal therapy. It is the third major cause for intra-abdominal soft tissue infections after streptococci and staphylococci. It is responsible for outbreaks leading to neonatal sepsis, meningitis, bacteremia, and neonatal UTIs, neonatal pneumonia. And predisposing factors for neonatal pathologies are like low weight, premature delivery, abdominal surgeries, and peripartum diseases of mother. Treatment and mechanisms of resistance. Resistance is defined as not killing of bacteria even with a dose 32 times higher than normal. For treatment, we have different regime for both the species. We have different regime for E. faecalis and different for E. faecium due to increased resistance in Enterococcus faecium. First of all, the antibiotics that we do not have to use are amikamycin, tobramycin, and single aminoglycoside. We don't have to use these medicines. So the regime for E. faecalis associated endocarditis is ampicillin, penicillin, ampicillin or penicillin, or vancomycin with one of the aminoglycoside, which means any of the beta-lactam, ampicillin, penicillin, or vancomycin with one of the aminoglycoside. Beta-lactam in itself is not effective against Enterococci species. Beta-lactam will just increase the penetration of aminoglycosides. So the doses of ampicillin are 12 gram per day IV per 4 hours. Penicillin 18 to 30 million units IV per day. Ampicillin and ceftriaxone can also be used. If we are using ampicillin and ceftriaxone, we don't need to use any aminoglycoside. The dose of it is 2 gram IV per 24 hours. Vancomycin is not better than beta-lactam. We have to use vancomycin only when there is hypersensitivity against the penicillins up to an extent of severity, that is anaphylactic shock. In ephesium, we will use the regime that is high dose daptomycin plus one of the aminoglycoside. Daptomycin alone is also effective. Aminoglycoside is added for the strains which are highly resistant. Linezolid, ampicillin plus aminoglycoside and ampicillin plus imipenem can also be used. For bacteremia associated with E. faecalis, the same regime will be there as in endocarditis, that is one of the beta-lactam plus one aminoglycoside. In this case, we can also use linezolid, that is in bacteremia. In meningitis, also the regime will be same, beta-lactam plus one aminoglycoside. Other options we have are linezolid and daptomycin or any other drug which is CSF active. For UTI, we have different regime. We have special antibiotics that can cross urinary, that can reach urinary bladder up to a better extent, that are fosfomycin 3 gram per oral, only one dose to be given, ampicillin 500 mg per 6 hours IV, nitrofurantoin 100 mg oral per 6 hours. The regime for UTI, ephesium and faecalis will be same, except usage of ampicillin will not be there in ephesium. For bacteremia also, in ephesium we have the same regime, that is high dose dapto and aminoglycoside. We can use linezolid and any of the CSF active agent, high dose daptomycin or any of the CSF active agent. Linezolid and dapto, they are alone active against ephesium, but for high resistant strains like vancomycin resistant strains, we have to use two drugs in a way for meningitis. Now resistance mechanism, they means if enterococci, they produces penicillin binding proteins that produces resistance against all the beta-lactam antibiotics, and they can change or remove the DLR residue of cell wall, and it causes resistance against vancomycin. Aminoglycoside modifying agents are produced against aminoglycosides. CIAFSR, that is cell membrane stress response produced by bacteria, is responsible for resistance against daptomycin. Resistance against linezolid is due to 23R RNA gene methylation, and against tigacycline is due to a STAN ribosomal protein. Thanks for watching.